paper breakdown. I'll give a couple of seconds for everybody to kind of trickle in here so we can. Does everybody hear me clearly? The last time I saw some hiccups in some of the portions of the video. Good deal. Greetings from Germany. Greetings from Florida. Liverpool, UK. People are trickling in. Okay. Well, I was kind of looking over what we went over the last time, and it looks like we finished up on the MCT oils and the exogenous ketones. So I thought I'd start out with the next slide, which is a really neat graphic about kind of how the overview of how to use metabolic therapy and kind of where it fits in the whole gestalt of patient care, really. And as you can see here, and obviously this is talking about GBM or glioblastomas, but there's going to be some period of time where you have an initial diagnosis, and you're going to get your CTs, MRIs, potentially biopsies, and it's talking about staging to figure out, like, obviously to what degree the tumor is extended past the original location. And every tumor has their own kind of TNM scoring system, and to figure out what's a stage 2 or what's a stage 3 or what's a stage 4. So in this portion of the process, we can use conventional medicine to our benefit, to figure out what we're dealing with actually, and to what degree. And what it says here is it talks about tumor diagnosis, including anatomical and metabolic stratifications, and then blood panel analysis and liquid biopsies, and tumor debulking or surgical debulking if necessary due to rapid disease progression, and then discuss the expectations and efficacy for all proposed therapies, including standard of care. And it says here that that's when a person, if they wanted to implement metabolic therapy, would start. They would start pretty much right after the initial diagnosis of your tumor, whatever that type and stage is. And then you would go into, starting to learn how to perfect your ketogenic diet. And, this slide has quite a bit of information on it. So it's obviously giving you kind of a picture of what your diet may look like with fish and steak and avocado. Although I do believe it's possible to go and do a ketogenic diet from a plant base or vegetarian, even vegan, way to do it. I think that it would be difficult, but I think it's possible, because of avocados and because of, olives and olive oils and stuff like that, coconuts. So it is possible, but it also shows fasting here. It shows kind of like a breakdown of the major macronutrients. But as you can see here, at least per this graph, 3/4 of your plate is going to be filled with fat because it's a high fat diet. And then here we have a little glucose meter. I'm guessing this is in millimoles, and it's talking about a graph here of where we're trying to in the first month, kind of for some people, tracking your blood glucose is pretty easy. You've been doing it for a long time. Maybe you have diabetes or pre-diabetes, or maybe you're just a health nut. But that being said, for some of us who've never tracked our glucose before, our ketone levels before, or tracked macronutrients or done, any degree of fasting, whether it be intermittent fasting, kind of daily or longer fast, you're going to have a period of time where you start to figure it out. It's going to be frustrating because you're going to check your initial GKI and it's going to be 10 or more. And, over time, God willing, with perseverance, you're going to get it to that less than 2. And it's the glucose in millimole over the ketone millimole is how you calculate your GKI, your glucose ketone index. And obviously this says less than 2, less than or equal to 2. But we ideally, like it says here later on down here, it says ideally it's less than 1 or equal to 1. And just to read a couple other things here, it says the food selection can be flexible as long as the GKI targets are maintained over time. And, this is where I personally kind of differ a little bit with this. Obviously I want to respect everybody's kind of like views in terms of what they want to eat. If it's an ethical thing, like for veganism, then go for it. It's going to be difficult, but you can go for it. But I think that food selection is important. Food quality is important. If you could be on a ketogenic diet, the most strict ketogenic diet ever, if you're on 100% seed oils, but that may not be the best diet for you to maintain your health. Yeah, it's going to give you a great GKI, but it may be doing, harm in other ways. So I do think that food selection matters a little bit more than it's kind of brought out here. But then they're going to track biomarkers, metabolic health, and tumor progression for feasibility and tolerability. And then what it's saying here is after you kind of perfect the initial metabolic therapy using the ketogenic diet by itself and fasting, then that's when they're saying add in the glycolysis and glutaminolysis type of medications and or strategies. And it's saying the risk versus benefit analysis for all standard and novel therapies after transitioning into therapeutic ketosis, effective targeting of glycolysis and glutaminolysis becomes the metabolic priming baseline for other therapies. And I find that that's a little bit interesting that they talk about ketogenic diet, therapeutic ketosis, the blockade or the inhibition of glycolysis and glutaminolysis or the glutamine pathways as the metabolic priming baseline for other therapies, yet it doesn't mention those other therapies. And I think what is missing, at least in my view, is that I think what's missing is the oxidative therapies. That's what this portion of the metabolic approach really does. It primes the body and the cancer to be destroyed, not the body, but the cancer to be destroyed by these other therapies. And these other therapies would be the oxidative therapies. Anyway, and then the fourth phase, according to this research paper, would be continued ketogenic metabolic therapy and monitor disease, consider combination targeting of cancer-associated pathways and tumor microenvironment, evaluate quality of life and survival. Salvage therapies can be added if metabolic therapy is insufficient to control disease progression. And I think that for a lot of folks, and it makes sense, we want to believe that you cannot see the slide yet. Can you see what I'm showing here? This slide here about the recommended timeline for dietary pharmacologic KMT research in GBM? No? What? All right, stand by. Just my face. That's scary. Sorry. All right, let me see what I can do here. So window, share. Do you see it now? Do you see the... You're welcome. It's my pleasure to do it. Do you see the paper now behind me? Works? Okay, that's good. I don't know what I did differently. That's the exact same thing I was doing, but stand by. All right, 1 second. I'm going to go back to the prior slide that I was looking over, the cool slide. You guys missed it. All right, stand by. All right, so this is the slide that I was referring to, and I'll just quickly go over it again. So obviously there's the figuring out you have some problem or some diagnosis, right? There's the investigative phases, and that could include some blood panel and even maybe early surgical if, God forbid, that's what's necessary to kind of preserve bodily function. And then here's the portion where I was talking about the fasting and the macronutrients and the fish and the steak and the avocado and the blood glucometer and the glucose ketone index, and also this kind of like the touch and go, trying to get it figured out type of a situation in the first couple of weeks of, starting the ketogenic diet and fasting and so on and so forth, and then adding in the glucose and glutamine inhibitors. Just did a Keto Mojo test at this moment. Exactly. GKI 1.0. That's right. Good job. That's perfect. And then I wanted to reiterate this because this was obviously missed on the initial pass here, is that after transitioning into therapeutic ketosis, effective targeting of glycolysis and glutaminolysis becomes the metabolic priming baseline for other therapies. And this is where I think that there should be like another, box here where it's like IV vitamin C high dose, like HBOT, hard shell, like those kind of things, as being the other therapies that are able to take full advantage of this metabolic priming baseline that he talks about here. And then of course it's the, continuing monitoring of that process over a long period of time. And I think this is where we can integrate, potentially with the standard of care or the conventional medicine, is that we can use their, PET scans, and we can use their, tumor markers and blood tests that, that can help us understand where we're at in this process, while still relying on this being the foundation of our therapies. So pretty cool. Let me go to the next slide here. So this is where you guys had first seen, and I don't think there's much really to talk about here. They have like kind of extensive tables about like what, essentially what kind of things should be done in each step, right? So this is just basically kind of a blown up version of this first step here, and really maybe a little bit more detail about, starting to do maybe some fasting, trying to affect your GKI. Starting to probably do a little like longer term fasting. And then he kind of like, goes on a little bit of a thing about how radiation therapies, how he talks about how it's probably going to be giving you some short-term benefit, but maybe not the long-term benefit you're looking for, because you're freeing up so much glucose and glutamine in the process. He talks here again about corticosteroids, or the use of like prednisone, or classically within neuro-oncology, they use dexamethasone, which is like another, corticosteroid that's going to raise your blood sugar, decrease inflammation, swelling. Sometimes it's absolutely necessary, depending on the case. But I think that we're pretty liberal with the use of corticosteroids. And I think as this becomes more mainstream, I believe that's going to be highly frowned upon unless it's absolutely necessary. And hopefully we'll start to tighten up our use of those, so we're not feeding the cancer, basically, the glucose. Physical activity, stress management. So here's kind of some more of, the 2017 paper, Press Pulse, talking about some other things you can do, whether or not it be exercise as a way to, here it says, resistance training preserves muscle mass, increases a major physiologic glucose sink, further enhancing ketogenesis through decreased insulin signaling. And I think I have a whole video on an exercise, and I'm not able to be very specific with the type of exercise that I recommend, just because the papers were fairly vague. Although I think it does make sense that resistance training be a cornerstone. Although kind of like cardiovascular sessions, they do burn a lot of glucose, especially if you're over a certain zone. The lower intensity cardios, like walking and things like that, just very low resistance, zone 1, zone 2 would be heavily probably fat burning. But the higher intensity cardio, but also resistance training is gonna see, like it says here, act as a physiological glucose sink, further enhancing ketosis. And then we also know that resistance training is going to also improve, it's going to steal glutamine as well away from the cancer cells, which is pretty cool. And then of course, stress management, the big reason for this, and it's kind of a vague term, stress management. Obviously, how many people can, get rid of their stress if they have a major cancer diagnosis. Like that's pretty impossible, right? But being able to manage it and deal with that in a more healthy way can be very helpful, because your body is producing its own corticosteroids. The cortisol system that's kind of raise your blood sugar without even eating. But there are many other things that can raise your blood sugar without eating as well. Things like blue light or EMF. So those are all things that I also talk about as kind of adjuncts. And this is just another way. This graphic here is just another way of looking at, essentially the graphic we saw here, so beautifully illustrated in another way. So you're looking at, here's a newly diagnosed glioblastoma multiforme. You're still trying to figure out like what's what. You can do what they call neoadjuvant ketogenic metabolic therapy. So, in oncology, there's this idea of neoadjuvant versus adjuvant chemotherapy, right? So it's kind of using the same, verbiage as that we would use for chemo, basically. And neoadjuvant generally means before surgery, and then adjuvant means after surgery. So they're saying basically before any surgical interventions even start, just get yourself on a ketogenic metabolic therapy, GKI adjusted and or fasting, before you even start. And then an elective surgery, and less life-threatening, of course, that's always, a very, very, very real possibility of it being a life-threatening situation. But if it's an elective surgery, and then do your baseline assessment after you have your debulking or your surgical resection, and then, here's, standalone ketogenic metabolic therapy, delaying the standard of care, or maybe adding in the standard of care, and looking kind of every 6 to 8 weeks, what your response is. Do you have stable disease? Do you have clinical progression? And then they have kind of like a little bit of a flow chart here for, what could happen, depending on your progress. And, this is just another kind of like neat graphic here where we're looking at all the areas where, a person could use support. Let's just be very honest. Like a lot of people have really no idea. Thank you, Paul. Have no idea, what they're doing with a ketogenic diet. They don't know how to track calories. They don't know how to track macronutrients. They don't know how to be in ketosis. A lot of people have no idea what ketosis is, right? So it would be very helpful for someone to, have a support system within the system itself, within the medical system. Of course, right now that doesn't exist to the degree that we need it to or we want it to, but that could, if your doctor was well versed or had the ability to guide you or help you with that, that would be one level of assistance or support that you could have. Or you could meet with a dietitian, and a dietitian who's well versed in the ketogenic diet. That would be helpful for a lot of people to do ongoing coaching, not only initial teaching about what it is, but also ongoing coaching. Maybe meeting with someone once a week or once every couple of weeks to look at your GKI trends and say this is where we need to do better. I think that this is actually really, really smart too. Individual counseling, and obviously that's vague. I took it a certain way. I was thinking about kind of like psychotherapy or kind of a psychologist helping you, manage stress, or, getting your cortisol levels down, helping you like maybe learn a meditative practice, or going through some traumatic events, to get past that and get unstuck with that stuff. One of the things that I do routinely see in clinical practice with this type of, situation is that a lot of people have, traumatic events, in the months and years that are prior to a diagnosis. And I think that for a lot of people, they kind of maybe don't connect the dots until someone points it out. And then they're like, oh, wow, yeah, that probably did have an effect. Or maybe you do know it, but you just need someone to help, validate that for you, that is probably a problem. And so individual counseling, although I think that they're talking about maybe dietary counseling, but anyway, I digressed. Let's see here. So informed patient with, so basically like there's an informed patient with support of a dietitian, and there's an informed patient with a whole host of healthcare professionals, including doctors, pharmacologic, help from the physician, synergistic, maybe with, either radiation or surgical interventions. I mean, I think there's the sky's the limit. It's just that we have to, start to implement this stuff, start to test it, see what works, what doesn't work, and set up an infrastructure, that allows this to be the case. I think it would be really, I think maybe the word cool is bad because, that means that it's cool people have cancer. But what I mean is that I think it would be really amazing if we could have, instead of, cancer centers like we currently have, where you go in and get your radiation and chemo and stuff like that, maybe a place where you can go get, IV vitamin therapies, IV vitamin C or HBOT, or, you meet with a doctor or your dietitian, or maybe other, integrative therapies, all in one spot. That'd be unbelievable. Imagine if you could go to your local, ketogenic metabolic therapy, clinic instead, and you could get all the support you needed there. On top of that, maybe they have, instead of having cookies with your chemo, maybe we could have, avocado with your IV vitamin C or something like that, so you could keep your GKI down. Anyway, digressing, but that's kind of what this is talking about, is kind of a future framework for what it could be, if this was able to actually catch on. Now, I particularly was interested in this. So, how do I say this? So he has like this very overview, and then he has kind of like a larger, like more, like detailed things. And then later on, he talks about like very specific things. And one of the things that I was curious about personally was what type of blood markers were they recommending? Because I have obviously my own panel of things that I do for people, and they take 10 tubes of blood, and unfortunately, I think half the patients want to pass out, unfortunately, because there's so much blood taken out. And I don't mean to jest about that, but I do want to know a lot of things. And so, like, I wanted to know what they were looking for. So, for example, biomarkers of general health include hemograms, that's also known as a CBC, electrolyte, hepatic function, that's also known as a CMP when they're combined, renal function, that's also in there in a CMP, inflammatory markers, HSCRP, ESR, ferritin, vitamin status, key dietary nutrients to monitor on a carbohydrate-restricted diet include carnitine, thiamine, folate, pantothenic acid, calcium, phosphorus, iron, vitamin D, and trace elements. And I think this is interesting in particular because, this is very well thought out, and I'll tell you why. I don't have a graphic on this particular PowerPoint because this PowerPoint's about the Duraj paper. But that being said, what's talking about is important cofactors for fatty acid metabolism. And, carnitine, thiamine, folic acid, I'm surprised B12's not on there, but other B vitamins, are very important for the metabolism of fat. And then, of course, vitamin D, I think that makes total sense. If your doctor's not checking your vitamin D quarterly, I think that I would find somebody else personally, but you need to be figuring out what your vitamin D level is. I would even say melatonin levels. I think iron makes sense. We usually check the ferritin to, how we clinically check that, and a total iron binding capacity. But trace minerals could be important too. I think that's important. Sometimes it's a little bit difficult to check for all those, in a lab test. And also even some of the B vitamins and some of these things like carnitine, it's a little bit difficult to detect, how do I want to say? It's difficult to detect directly in a blood test, but there are, urinary organic acids, there's ways to look at, your vitamin and status and how that's affecting your, the metabolism of certain things. And I think this is where, this gives me a lot of hope because, if there's one thing that, integrative and functional medicine doctors can do, like at baseline, is they can, they know about diets. They know about how to work up, like insulin resistance and things like that. A lot of functional medicine doctors have a lot of, experience with, organic acid levels and stuff like that, or, 4-point cortisol testing, sex steroid testing, through the, using of the, I use a test called the Dutch test, for example. There's a lot of people out there who know how to do that, and still could be very beneficial for us in the metabolic world, because that's really, honest to God, that's what they need to know how to do to help you with, at the end of the day. There may be need for like specialized people, who know more about ketogenic metabolic therapy, but most physicians and definitely like integrative and functional medicine doctors like can help you with all of these things, to figure out what blood panels you need. They do recommend. So this is an interesting point. He mentions metabolic stratification. Well, what does that mean? At least for Dr. Seyfried and Dr. Tomas Duraj. Well, they recommend getting standardized metabolic imaging, glucose uptake, the 18F FDG PET scan with anatomic imaging for all GBM patients, which may offer improved staging and delineation of surgical margins. A fasting period of greater than 12 hours is advisable prior to the scan to facilitate 18 FDG transport into the tumor and lower insulin-mediated glucose uptake into the surrounding tissues. Let's see here. Is there anything else I want to mention on this slide? So basically, what he's trying to say here is that they want to use PET scanning as a way to determine how hungry is this tumor for glucose. And I think that's really interesting to use existing technology in a way that allows us to know, is this tumor really hungry for glucose? Because I do believe that some are more hungry for glutamine than glucose, although they do require both chemical substrates. And it says here that in this next portion, you would actually, start dietary ketogenic metabolic therapy. And there's this paper's 50 pages, so obviously I'm not going to read every single thing. I think that would be counterproductive, but I did highlight some things here. So like a well-formulated ketogenic diet should proactively avoid common side effects such as electrolyte imbalances or undesired lean body mass loss to minimize negative impacts on quality of life. Initial weight loss during the transition to nutritional ketosis and fasting is mostly due to diuresis, or the loss of water weight, and fat loss, not lean body mass. Adequate hydration and electrolyte supplementation, sodium chloride, magnesium, potassium, is recommended for both ketogenic diets and fasting. And I think I've kind of mentioned this in the past. I do believe that protein should probably be titrated up to see where you can tolerate. So this is actually a little bit more of a liberal ketogenic diet than what I've seen in other papers and graphics, where it's like 90% fat, 5% carbs, 5% protein. And I do find that a lot of people that I work with or have had contact with in this space, one of the difficulties is getting their GKI down, getting their glucose down. And, protein, although it has much less of an effect than carbohydrate on insulin signaling and potentially raising your blood glucose, I think that I would start at the more extreme version, especially if I had something like a GBM. I think I would start at the more extreme version of a very low protein diet and get your GKI down. And then what I would do is I would probably titrate that protein up as a way to help preserve muscle mass. But I will be honest with you, I don't believe that the preserving of muscle mass is only, or even the majority of the reason is due to protein. I think if you don't give that metabolic stimulus, right, to the muscle cells to say, hey, we need to keep you around while we're in a calorie deficit or we're on a very low protein diet, by doing resistance training, I think you're going to have not near the success you're going to be looking for, despite how much protein you take in. That's my personal opinion. I do think that it's well known that when you start ketosis that you're going to lose some weight and it's going to be water weight. That's true. I think this is where, maybe a DEXA scan is a little bit far-fetched regularly, but maybe like one of the InBodies or like one of the, fancy scales that allows you to check, for fat mass and lean body mass could be very helpful here to see, like, is this weight fat? Is this weight, lean body mass? And it can be a little bit more, exact on how you're actually checking these things clinically. And then, I personally do like adding in electrolytes to my water also. I think, fasting is difficult because if it's a short fast, like a 18-hour fast, like that's probably not a big deal at all, as long as you're eating enough in your feeding window and not overdoing the water. But it's when you start doing longer term fasting is where I personally believe that you should probably have physician oversight, because hyponatremia is a real thing, and you can actually die of it. So most people don't, but you can have significant side effects, seizures, significant, encephalopathies or confusion. So it's nausea, vomiting, headaches. It's bad. So you don't want to add more morbidity to yourself than you already have. So I do think that if you're going to do longer fasting, probably longer than about 2 or 3 days, I personally think it would be useful to have at least a basic metabolic panel or comprehensive metabolic panel, and then doing one after your fast. Again, that's up to your doctor and how you want to do it. If it's a longer than 3-4 days, then maybe if you're doing like a 7 or 10-day fast, maybe even having a BMP in the middle of that, or if you experience any hyponatremia type symptoms, could be beneficial, because you don't want to be in an ICU, because then you're under blue light, then you're getting whatever food they give you and all the stresses of being in a hospital. So your GKI is going to be destroyed that way. So I think it's better to be safe than sorry and just be really careful with the fasting. And it's, again, I'm going to reiterate, working with a local doctor who's like-minded, and then ultimately it says combinatory approaches rather than a single pathway targeting may be necessary for optimal results. I completely agree with that. I think that if you're not going to succeed likely, and I'm not God, I don't know for a fact, but you're unlikely going to succeed on a ketogenic diet by itself. You're unlikely going to, succeed on a ketogenic diet unless the GKI and the glucose is down at a certain level. And you're not going to succeed unless you block glutamine as well. And you're probably not going to succeed unless you're doing the oxidative therapies on top of that. It is a whole package, and blocking just one pathway, whether it be glucose or glutamine, or starting to do oxidative therapies without blocking glucose and glutamine, you're not going to be getting the maximum benefit, to say the least. So here is a timeline. I'm going to go to the comments real fast. Hello from Atlanta. Yes. Hello, Alan. So the timeline of drug administration is outlined in Figure 5 and can be structured as follows. So I'm pretty sure Figure 5 was this figure here, but I'll go back down here. So Figure 5 says that in A, we start the ketogenic metabolic therapy using a GKI adjusted ketogenic diet or a ketogenic diet restricted and fasting, reduces glycolytic dependency of normal tissues and stimulates compensatory ketone body metabolism. We know that. And then if the tumor is shown to be glycotic, high 18F FDG intake, this is where we're using the PET scan as a way to figure out exactly how we're going to set up our ketogenic therapy. Consider additional systemic targeting of substrates such as renal glucose reabsorption of gluconeogenesis inhibitors, SLG2 inhibitors, or metformin. Direct inhibition of glycolysis should be administered only after reaching sustained therapeutic ketosis to improve safety and tolerability, aka if you're keto adapted. Therapeutic targets in early clinical trials include hexokinase, aka hexokinase inhibitors, basically. 2DG is a very well-known one. Lenalidomide, 3-bromopyruvate. Honest to God, I don't know how you're going to be able to utilize these in clinical practice. 2DG, I could see under guidance. Phosphofructokinase, there's 3PO again. Again, not able to find. This is where I think that we have an edge. Okay, so they're giving very very small not small, but very few examples here, right, of things that can block hexokinase or things that can block phosphofructokinase or pyruvic kinase. And unfortunately, most of these things you're not going to have access to. But don't lose hope, because there are so many things that block these enzymes. It's not even funny. Like when we get to the glucose side of the house on the channel, aside from this paper, you're going to be very reassured, okay, because there are tons of things that block hexokinase other than 2DG or these other drugs and other, these other enzymes along the along the glycolysis pathway. Okay, so don't worry if you've never heard about ACT PFK 18158. I haven't either. Don't worry. We propose that concurrent targeting of glutaminolysis is essential to avoid therapy resistance. At this time, one of the anti-glutaminylytic drugs considered to work best as part of ketogenic metabolic therapy in preclinical models is the pan-glutaminase inhibitor 6-diazo-5-oxo-L-norleucine DON. Any prospective compound that can safely and effectively target glutamine availability and or utilization may elicit comparable effects, such as a DON prodrug or novel glutaminase inhibitors. Additionally, tumor-specific delivery of DON is being investigated as an enhancer of anti-tumor immunity. Interesting. So I think what they're saying here is that they are looking at injecting DON directly into the tumor, not into systemic circulation, so that the rest of your immune system is not affected, or your gut. That's pretty cool. After cancer cells have been rendered vulnerable by press-pulse metabolic pressure, cancer-associated pathways and tumor microenvironment can be targeted via synergistic drug combinations. Oh, please tell me they're going to talk about the real hammer, which is oxidative therapies. I'm very surprised. Okay, well, it doesn't. So let me just tell you that D, in my opinion, my humble opinion, should be HBOT, high-dose IV vitamin C, or things that cause an oxidative stressor, because that's basically what we're doing here. Now, I think that cancer-associated pathways in tumor microenvironment makes a whole lot of sense. That could be like an E, F, or something else, but D, in my opinion, should be oxidative therapies. And that's what was in the initial press pulse paper, if you remember back that graphic that has at the very bottom HBOT. I think that makes more sense personally. Okay, the next topic is the pharmacologic targeting of glutaminolysis. And let's see here. Yes, I know. They have many. How do I want to say it? First of all, they do mention dietary supplements later on, but they also how do I want to say it? They have the supplemental materials, which have a bunch. But I'm telling you, like, that list is nothing. I mean, it's nothing compared to like the list that we've built over, even talking about SLC 7811 and SLC 185 and all the glutamine uptake channels, as well as glutaminase inhibitors. Like, there's other ones that there are not in that supplemental materials that we are able to find looking through the medical literature. And I find it seems like we find something every day. Now, it's not only me who finds them. It's like other people in the audience who are very intelligent and who also are very diligent at looking through the medical literature, and they like send me a paper via email. I'm like, oh wow, I didn't know about that, and it's actually stronger than DON. Who knew? You know what I mean? So there's a lot of stuff out there that's being investigated that really is not on the paper. The paper is fantastic. I'm just telling you that there's a lot more out there, which is pretty cool. All right, so again, this is a pretty long section, but I'm just going to say that currently novel glutamine antagonists and other metabolic inhibitors such as DON prodrugs or CB839 are being investigated as monotherapy additions to standard of care. Doesn't make any sense if you're not using ketogenic therapy, but anyway, I'll digress. Single pathway inhibition may not be optimal due to functional redundancy. Let's see here. So this is just giving basically a background about what DON is. I do think it's probably important to mention here that continuous daily parenteral, which means like IV or IM or sub-Q injections, produce dose-limiting side effects in previous clinical trials, most notably oral mucositis, which is where kind of like your mucous membranes kind of break down or get inflamed, nausea, vomiting, myelosuppression, lowering your immunity, or even your red blood cells and your entire, kind of like bone marrow lines. Pre-medications with antiemetics or things that can help reduce nausea, vomiting, like Zofran, can be implemented prophylactically. Instead, congruent with short half-life, low-dose intermittent administration would be preferable, as suggested by the initial dose escalation studies. Thus, future research may consider parenteral or oral administration in the 0.2 to 1.1 milligram per kilogram per day range, adjusted for individual tolerances. Dosing frequency, continuous or intermittent, will be contingent upon route of administration, anti-tumor response, and safety. In recent phase 2A studies, DON has been administered 140 milligrams per meter squared twice weekly in 15-minute infusions, combined with plasma glutamine depletion. So let me just tell you that Dawn, there are like so many different types of dosing strategies. And, to be very frank, what I saw in the literature was that oral dosing daily was the best, which does not fit within Press Pulse, but they're going to address that to some degree. So while Dawn Pro drugs are with improved oral bioavailability are being developed, the original compound demonstrated biologic activities at oral doses up to 1.1 milligrams per kilogram per day for a duration of 2 weeks or more. Dawn has been administered orally as a single daily dose without resting periods continuously, split dosing every 4 to 6 hours with higher incidence of side effects such as oral mucositis, or split as a single or split dosing given intermittently over 2 to 4 days, lowest incidence of side effects. Based on previous clinical testing, the recommended starting point would be a lower daily dose taken with a fatty meal vehicle in a single 0.4 milligrams per kilogram every 24 hours, or split schedule 0.1 milligrams per kilogram every 6 hours, with a 1 to 3 day resting period depending on side effects, increasing to 1.1 milligrams per kilogram or higher based on tolerance and pharmacokinetics. Single 1.2 to 2.5 milligrams per kilogram oral doses were necessary to reach serum peak concentrations. And then later on it says increased fiber intake may reduce off-target damage to the oral and intestinal mucosa. This is kind of a pearl. I would really write this down. Increased fiber intake, like psyllium, for example, can be used to reduce basically like to reduce side effects, especially in the GI tract, because it's highly dependent on glutamine. And so that can really help, maintain side effects. So what I would say is that this is a pretty confusing paragraph for most people to look at. They're talking about daily, this dose, and split dosing it during the same day, and this dose, and using different doses, and then talking about significant rest periods. So I mean, this even in itself doesn't really make a lot of sense, right? 0.4 mg per kg every day, and then it says with a 1 to 3 day rest period, like that. I get what they're trying to say. They're trying to say just giving it once per day, but it would make more sense 0.4 mg per kg once, and then or Q6 for 1 day, and then every 1 to 3 days, depending on what your side effects are. I'll just say it. Again, Dawn in a vacuum, Dawn by itself, not Dawn with keto, not Dawn with HBOT, not Dawn with anything else. The daily dosing was the most effective. Does that mean that these kind of dosing strategies are not more effective because they're being used with a ketogenic metabolic therapy? My gut tells me that they know what they're talking about. It makes a heck of a lot of sense. And it also makes a lot of sense. They don't mention it in this paper, but it makes a lot of sense to be using Dawn on the days that you do HBOT and being in a maximum, either fasted or very low GKI state at that time as well with a low glucose. But I'll digress. It doesn't mention it on this paper. So I just want to mention this because I'll be very frank with you, I'd never heard of this medication. And even in the kind of what do you want to call it, in the pretty extensive searches that I've done looking at the glutaminylases pathway, I'd never come across this. But anyway, sodium phenylbutyrate is a clinically approved orphan drug for urea cycle disorders and neurodegenerative diseases with potential anti-tumor effects as a single agent or co-adjuvant with glutamine antagonism. Phenylbutyrate rapidly metabolizes to phenylacetate, conjugated to phenylacetyl-CoA and glutamine, acting as an ammonia scavenger and inducing durable plasma glutamine depletion. And it is also being investigated as a histone deacetylase inhibitor. Clinical trials in solid tumors noted a sustained dose-dependent reduction in plasma glutamine with oral doses between 180 milligrams and 360 milligrams per kilogram per day, up to a maximum tolerated 27 grams. Wow, per day. That's a lot. Phenylbutyrate decreases systemic availability of glutamine, resulting in a substrate competition, thus similar to PEG glutaminase or phenylbutyrate-induced glutamine depletion may be explored to reduce dosing requirements of Dawn. or other enzyme level inhibitors of glutaminolysis. So what this essentially is doing, from what I can understand, is it's actually like scavenging glutamine from the plasma. Okay, that's actually a unique mechanism that we have not on this channel talked about whatsoever. Basically, we've talked about blocking glutamine uptake through various uptake channels. We talked about two of the major glutamine enzymes, the glutaminase enzyme, which is where DON blocks, also several other things, which we'll talk about. But then the glutamine dehydrogenase enzyme, which is what EGCG blocks, but again, other things block it. And so what they're talking about is actually like just removing glutamine from the actual plasma of the blood, right? And that's like another kind of a tertiary mechanism. And I mean, I think if it's safe and if it's not going to cause significant side effects, and what it's saying here is it may reduce the dosing requirements of DON and other enzyme inhibitors of glutaminolysis. Maybe it will work in a synergistic way that allows us to use DON less frequently, or maybe a dose that's a lower dose, and make it more tolerable and make the whole thing more tolerable, which I think is pretty cool. And yeah, okay. Let's see here. So let's go back to the slides here. So that's kind of like the glutamine piece of it, although it does mention here that repurposed drugs with potential inhibitory effects on glutaminolic pathway include amino oxyacetate, apomorphine, tamoxifen, raloxifene, sulfasalazine, and ceftriaxone. Over-the-counter nutraceuticals with direct or indirect effects include EGCG, xanthol humol, hesperidin, uracilic acid, caffeic acid, curcumin, apigenin, berberine, and other compounds with only preliminary mechanistic evidence. So obviously, we've had a whole micro series, it's almost like a macro series at this point, on glutamine inhibitors, and there's obviously dozens more than these. And I do believe that even if you were to use DON or sodium sodium phenylbutyrate, I think it would be useful to add these kind of things in, because these things, for example, curcumin blocks glutaminase. It also blocks SLC1A5. It blocks 7A11. It blocks several compounds. Uracilic acid blocks SLC7A11. I believe it also blocks. Well, I don't remember exactly where it blocks, other than SLC7A11. But anyway, berberine blocks SLC1A5. It also blocks glutaminase. So my point is that these kind of things work in synergy, and in general, most people don't have a lot of side effects from supplements. So I think that could be used in a synergistic manner, and I do think that would be important. But I do think that there needs to be a lot more research done. These are mechanistic studies; they're not really done in combination with ketogenic metabolic therapy as a whole. I do think that the thing about the injecting the DON drug or the DON prodrug into the tumor itself to minimize the collateral effects of glutamine inhibition is pretty freaking cool. I never saw that until this paper. Okay, so here is a little bit more about over-the-counter supplementation. And what it's saying here is, as a general concept, lifestyle interventions and supplementation are intended to improve adaptive capacity of the non-tumoral cell mass, the prevailing portion of the patient's ecology, which will compete with the tumor for bioenergetic and biosynthetic resources. This also improves the likelihood that targeting glycolysis and glutaminolysis and the tumor microenvironment will be better tolerated by normal cells, or that synergistic opportunities may arrive. I agree. I think this is an underplayed portion of this. Synergistic opportunities are really, I think, are really underplayed in this in general, because I think that I do think there's like a 1 + 1 = 5 type of thing that happens with some of these things. I think the most classic example was how if you add iron by itself or aristin by itself, which blocks SLC7A11, a glutamine cysteine antiporter, you saw some effect at 80 hours. And then if you added them together, you saw like a 5 or 10x, improvement for cancer cell killing through ferroptosis. So I think that there is a synergistic opportunities that are not being accounted for completely, but I'll digress. Future work needs to be done. It is exceedingly unlikely that large randomized clinical trials will ever be performed for non-patentable natural products. I mean, I think that's a given, but I think it's sad we have to see that in print. Consequently, we encourage documenting and sharing individual clinical experiences via systemic case reporting in peer-reviewed, reputable scientific journals. I think that's where we, as the audience, could do more, to this paper. Either working with, Duraj and Seyfried and his group to figure out if we can set up some kind of a case reporting, like system where you can like share your, story about how you, had stability of your disease, or, you became NED, and you kind of put it in some kind of central database where then the researchers can then publish those, N=1 type stories as a way to help maybe gain traction, and not just have this thing be a, just an academic experiment, basically. Physical activity. So we've talked about physical activity on a different video, but as a core pillar of ketogenic metabolic therapy, physical activity is an anti-cachexic, increases insulin sensitivity, and facilitates physiologic glucose and glutamine clearance. Basically, it steals glucose and glutamine away from tumor cells, out of the blood. Furthermore, low intensity endurance exercise such as regularly spread out walking, smaller doses but higher frequency, modulates osteocalcin and glucagon signaling, consequently lowering glucose availability and insulin secretion. I think this is a great point. I was actually thinking about this before presenting this today, and I was thinking how, like, obviously, the resistance training is something that's going to really pull glucose and glutamine out of the system as a way to help, maintain muscle glycogen, as well as, repair of muscle tissue that you break down. So I think it would be important to do, the resistance training, but you can obviously overtrain. You can obviously, there is a point of you're actually doing more harm than good. You probably can't, although, some people would probably argue, and who have more knowledge about the subject than me, you're probably not going to be doing like 2 a days or 3 days of resistance training. You're probably doing once per day or once every other day, maybe. And what I'm trying to say is that it's real. It says it here, but it says that, basically like short walks throughout the day are a way to continually clear out glucose from the system and create a metabolic demand that helps your cause from allowing the tumor to take all the glucose. This is where I'll have a whole video on this, but also cold thermogenesis or cold water immersion can do the same thing, and it can steal glucose away from tumors. Pretty cool. All right, so what it's saying here is ultimately that to aim for at least 150 minutes per week. It's a very standard recommendation. Aerobic activity and 2 or more days a week of resistance training, and or greater than 10 metabolic equivalents or METs of physical activity. So pretty standard recommendations there. I'd hope that we can maybe, as time goes on, and maybe if we could have some like exercise physiologists who are interested in cancer treatment, maybe they could have do some like more specific, okay, like maybe, like high intensity interval training, like is the best at bringing glucose out of the system, and this type of resistance training is the best for getting glutamine out of the system, or maybe walking or light jogging, or kind of more zone 1 or zone 2 is better for this particular metabolic effect to help starve tumors. I think that would be really neat if we could have like really specific exercise recommendations. But the bottom line for now, it's just like get moving to the best of your ability. Don't hurt yourself, obviously, but get moving. I think is a word of wisdom from the authors here. And here's a conclusion. So ethical considerations of future direction. So one of the greatest challenges in GBM, or glioblastoma multiforme therapy, is the inability of the current standard of care to eliminate all microscopic tumor infiltration and cancer stem cells. After the inevitable recurrence, patients are often confronted with salvage therapies of limited clinical utility. As predicted By evolutionary biology, cancer cells suffer from a distinctive lack of adaptability or adaptive versatility due to both mitochondrial and genomic damage, as well as persistent anabolic demands. GBM cells, like most other cancers, are comparatively more dependent on substrate level phosphorylation, or the Warburg effect, for energy and biosynthesis due to universal defects in mitochondrial number, structure, and function, despite ample downstream mutational heterogeneity, metabolic reprogramming, and single cell heterogeneity. Ketogenic metabolic therapy is conceptualized as a press-pulse therapeutic strategy. This framework can be adjusted for any cancer subtype, So if you have a question, does my non-Hodgkin's lymphoma, or does my myelodysplastic syndrome, or does my, pancreatic cancer, it's any cancer subtype that is unable to proliferate under relative restriction of both glycolysis and glutaminolysis, SLP dependency, even when supplied with compensatory oxidative fuels, OXPHOS insufficiency. Given the biochemical underpinnings, it will be important to search for cancer models that retain uncontrolled cell proliferation using primarily OXPHOS after the simultaneous targeting of glycolytic and glutaminolytic SLP flux, as would pose an exception to the mechanistic rationale. So that's a lot of words to say. Basically, they're going to keep looking essentially for cancer subtypes that don't rely on glucose and glutamine. They haven't found it yet, but they will keep looking. And if that arises where they can find a cancer subtype that doesn't, rely on glucose and glutamine and is using OXPHOS, right? Basically, how do I want to say it? Intact functional mitochondria that are making energy through OXPHOS, then that would be an exception to this mechanistic rationale. It probably is not going to have as much of an effect on you than it would if it was one of these cancers. But they're saying that they have not found that model yet. They're still looking. Future research stemming from the collection of case reports and clinical trials will offer unique insights into the optimal dosing, timing, and scheduling, and maximally safe and effective SLP targeting. So that's pretty much the paper as so far we have laid out. There is one graphic that I want to show as a gestalt here. So this is just another way of looking at basically the exact same thing we've been looking at other graphics, but as well as in the text, the actual text. And it's giving a little bit more, what do you want to call it? A little bit more detail, I'd say maybe. So obviously the first step is getting your GKI less than 2 through ketogenic diet, fasting, etc., and reducing the glucose availability just by diet, fasting, and food, right? Then they're saying adding in, particular, inhibitors, and that could be SLGL2 inhibitors, that could be insulin sensitizers, that could be carbohydrate absorption blockers, research-based drugs. I actually think there's a lot of things you can add in there because there's a lot of things that can block glucose and glutamine, or glucose in particular, from a natural perspective. But I'll digress. And then targeting glutaminolysis, either via DAWN or DAWN-like compounds or sodium phenylbutyrate. Again, this is where I have to say that there are a lot of other things that I think could be beneficial here. We've talked about many of those things on multiple videos. And then I have to say, how do I say this without being disrespectful? I think the paper is fantastic, and the graphics are, I think it's moving the area of science that we need forward, okay? Big time forward. And look at this graphics. These are beautiful, right? But okay, this is where I think they struck out. I really do. They're saying that step 3 is targeting tumor microenvironment. I don't know. I think that this should have been easily HBOT, high dose IV vitamin C. I think they missed it here. I think that this is also very important. Like gut microbiome, like that's down the list. I think that's down the list. But I think these are all important. Okay, and I think this is very well thought out. Okay, this is very comprehensive. But what's sadly missing here is the oxidative therapies as outlined in the 2017 paper and that is not really talked about here. I think it's big time missing. I think also what could be arguably missing here is just the entire, ferroptosis. It says apoptosis, and that's, it could be talking about a gestalt of, programmed cell death, but I think ferroptosis is also missing here. And of course, that's how a lot of the oxidative therapies work. It's how radiation works, as a matter of fact, in the right setting. But I think ferroptosis could be missing here. I think the targeting of SLC7811 is missing. So bottom line is, it's a beautiful paper, beautiful graphics. I think it's well done. I think it's very helpful clinically. I think it, how do I say this? I think it really puts us forward in terms of how to implement this in a clinical strategy. There's no doubt about it. This is really, really, really helpful. I do think that the appendices are really good also. I mean, we're starting with mebendazole, right? So like, it's got to be good. So my point is there's another, for me, another like 10 slides for the appendices that I want to cover in a separate live, maybe Thursday or maybe next Monday. But bottom line is, that is the Seyfried Duraj paper as I wanted to present to you. I hope that it was helpful for you all. If I could give you one piece of advice, other than finding a local like-minded doctor to help you implement this, would be download this paper, read this paper, read the indices or the abstract, or not the abstracts, but the supplemental materials. There is so much meat in this paper. No pun intended. There's so much to this paper that I think is beneficial for clinicians, for other researchers, for patients and loved ones of patients. I think many people can get a benefit from this paper. And I think I do believe that that they deserve a medal, because this does push us forward into the future of having metabolic therapy be, God willing, the new standard of care. And the old standard of care becomes, the last ditch efforts, but anyway, that could be wishful thinking on my part. Is there any last minute questions before I sign off here on this paper? Yeah, I think that while I'm waiting for any questions to pop up, that metabolic therapy works best with the most aggressive cancers. Yeah, I mean, if you look at, I don't have it in this particular PowerPoint, but if you look at, the initial, thank you very much, Danke. If you think about the graphic where it has the mitochondria that's like intact, and you have like the mitochondria that's like vacuolated, it has no crista, and you look at like the graph where it has like, oxphos is like 90+%, and then it goes down like this to near zero, and then substrate level phosphorylation is like 5% or less, and then it goes all the way to like nearly 100%. And on the bottom it says malignancy, right? So as the cancer becomes more cancerous, and as it gets more mutations in the mitochondrial DNA and subsequently the nuclear DNA, then the mitochondria are less effective. And I do think that metabolic therapy makes more sense there. But that's the same way with chemotherapy. Chemotherapy works the best on highly proliferative cells, right? Because they're utilizing, the proliferation. My thoughts on chaga mushroom is, I think it's wonderful. I have chaga mushroom tea in the other room here. I'm going to do a whole series, guys. Once we hit glucose, glutamine, once we hit like lactate dehydrogenase inhibitors and PDK inhibitors and all like the metabolic stuff, like, because I want to have you have the maximum amount of tools in your tool bag to bring to your doctor, your like-minded healthcare practitioner for the metabolic strategies. What I would say is that then I have like all these other strategies that I think that it would be stupid to forget. Like, I think that the medicinal mushrooms are powerful. Chaga is just one of them. Like reishi is another one. There's Agaricus blazei. There's all the other like medicinal mushrooms. Lion's mane. All of them. That have potent anti-cancer effects, and I think they could fit into a program. And as a matter of fact, I do particularly use them in my programs as well, in a certain portion of the program. I think it could be very useful as well. But let's see here. Which ketone bodies work best? Can exogenous ketones help? quantity, acetoacetate or BHB. So most of the supplements that I've seen that are exogenous ketones are beta hydroxybutyrate or BHB. And I think that I can't really. I would say that there's a lot of good ones, like the ones from Audacious Nutrition, the Keto Starts. That's like, I think that's somehow affiliated with Dom D'Agostino, and he's like the ketone like expert in the world, right? Like, so I would have to defer to him. And I think that he says that the ketones found in the Keto Start is kind of the best, like a racemic mixture of like of ketone bodies that have more effect on, basically no matter what kind of ketones you use exogenous, the cancer cells can't utilize them. But the ketones, they have different, there's different ketone bodies that have more effective, like an anti-cancer effect. And so I'll just have to digress to Dom D'Agostino in that one. But yeah, there's a couple that I recommend. The Keto Start's one of them. There's like a Perfect Keto ones that I think are pretty good. I've tried Dr. Boz's. They're not bad either. They all taste about the same. I'll be honest with you. They're not like, there's not like a gourmet like meal, but they're not awful, and I'm pretty used to taking a lot of supplements. So like, I'm kind of like probably more callous to nasty tastes, than most people, but I would say that they all taste about the same. The taste, you're not going to see a lot of difference. If there's a marketing ploy for taste, they're probably pulling wool over your eyes. But when it comes to like efficacy and different types of ketones and stuff like that, I think that could be an argument that can still be made. Let's see here. Drink chaga while fasting. Yeah. Oh wow. 8 days into it. That's a long fast. I mean, I hope that someone's at least checking your like a basic metabolic panel, because I'd hate for you to have like an electrolyte abnormality during your time here. But as long as you're not overdoing water, that's the key. Is you want to not underdo water. That'll raise your sodium, and then overdoing water will lower your sodium because you're not eating. And so that can drop your sodium and cause hyponatremia, which can be life-threatening. Okay, like I put people in the ICU with hyponatremia if it's to a degree. So it's not something to mess around with. You should be checking or having your doctor check those levels. Okay, well, I think I'm going to sign off. It's been about an hour and 10 minutes. I'd like to finish off this paper going through the supplemental materials, like either maybe Thursday or Monday. I'll send out a notification prior to doing it. It won't just be like random. So that way you have a little chance to prepare. It, honestly, God, it will probably be Monday because I do work at the hospital starting today, 12-hour shifts, 7 in a row. So I will probably be out of commission Thursday, but we'll see. If I can get her done, I'll get her done, and we can get this paper finished up. Okay. All right. God bless everyone. I hope everyone got benefit from this paper. I do recommend downloading it and reading it for yourself, and maybe then going over the videos together again as a way to kind of solidify understanding. Until next time.